Y sigue subiendo el número, gracias, os vais incorporando a este webinar. Bienvenidos todos a este webinar conjunto entre la SEMICYUC, la Sociedad Española de Medicina Intensiva, y la EuroELSO. Os vais incorporando poco a poco. Estamos encantados de teneros virtualmente entre nosotros. Esto es una colaboración, probablemente la primera de muchas, entre estas dos sociedades. Sociedad referente del paciente crítico en España y sociedad referente en ECMO en Europa, sin duda. Concretamente desde la SEMICYUC, que esto es una propuesta del proyecto ECMO. Yo creo que el proyecto ECMO es una propuesta, valga la redundancia, muy importante, a mi juicio, muy importante para el paciente crítico que necesita el soporte vital extracorpóreo. Yo creo que cuando propusimos la creación de este proyecto, quisimos que fuera algo muy práctico, que al final impactase en los pacientes realmente. Obviamente el impacto en los pacientes hay un paso previo que es el impacto en los especialistas, ¿no? Y por eso hemos querido que sea productivo, como digo, vía este webinar, que es un proyecto educacional muy interesante, que espero que sea de vuestro agrado. Links con sociedades internacionales, como esta, como EuroELSO y con otras. Creo que es importante. Todo este networking, como digo, impacta directamente en el paciente crítico. Las jornadas en Madrid, Edu, finales de febrero, 26 y 27. Nos vemos en Madrid. Jornadas ECMO, primeras jornadas ECMO, ponentes extraordinarios, nacionales e internacionales. Os invito a que os registréis y a que os inscribáis y nos vemos en persona en Madrid. Y también próximamente la revista de Medicina Intensiva veréis una publicación de una serie que publicaremos sobre soporte vital extracorpóreo. De un lado, por tanto, SEMICYUC, Proyecto ECMO, y al otro lado la EuroELSO, que es parte europea de la ELSO. Muchos de vosotros la conocéis y os invito desde ya a adheriros a la ELSO. Adheriros a la ELSO vía EuroELSO, que es, como digo, la sección europea de esta gran sociedad. Y solo hay que leer las publicaciones sobre ECMO. Siempre está presente, siempre está presente. En los años recientes ha habido una incorporación, y es una buena noticia, de centros españoles que se adhieren a la ELSO, pero no están todos. Y es bueno, como digo, en general, desde un punto de vista científico y clínico, que los centros que ofrecen soporte con ECMO se adhieran a esta sociedad. www.elso.org. Y hoy, ¿qué tenemos para hoy? ECPR, ECMO RCP, la aplicación del soporte vital extracorpóreo en la parada cardíaca refractaria. Dinis, Ingrid y Michael, los veis en pantalla. Serán adecuadamente presentados. Cuando nos oigan y nos entiendan en inglés, lo haremos tranquilos, aunque saben algo de español. ¿Qué tenemos concretamente de ECMO RCP? Que es un tema apasionante. Yo creo que es un tema que es la cresta a la ola, ¿no? En ECMO, podemos decirlo así. Dos cosas. Primero, aspectos organizativos e indicación de paciente, indicación de caso con Dinis, y posteriormente ajustes técnicos durante el proceso del manejo inicial, que también es extraordinariamente importante. Y ahora voy a cambiar al inglés. I would like to switch a little bit to English because I would like to personally and sincerely thank the speakers who are here, 3 speakers, for their exceptional kindness and willingness to help us here in Spain, to share their vast experience with us. And I truly believe that this networking is very impactful in our patients, and they are ultimately the very reason behind everything we do. So thank you very much for being here. Eduard and Nora will present yourselves. I have to say firstly hello to also the audience who do not speak Spanish. The presentations will be shared in English, obviously. Then what we are going to try to do, Nora, Edu, and me, is translate these questions in Spanish to English, share with the speakers, and then back from English to Spanish and share then with you. And I will tell this in Spanish in a minute. But I would like to say hello to all of you who you are English speakers. Cambio de nuevo al castellano. Acabo de decir que, por favor, interaccionar con nosotros. Esto lo creamos para vosotros, absolutamente. Si tenéis dudas, ya veo una ahí en preguntas y respuestas o en el chat. Nos podéis preguntar, las compartiremos con los ponentes y las traduciremos adecuadamente hacia vosotros. Os tengo que decir que hay más de 650 registrados en este webinar. Ya me callo, Edu, que me enrollo mucho y me dejo para el final lo más importante, que son Nora y Edu, que co-moderaremos este webinar conjunto. Gracias por estar aquí, Nora, gracias por estar aquí, Edu, y adelante. ¿No, Edu, qué tenemos como primera presentación?
¿Qué tal? Hola a todos. Simplemente repetirme lo que dice Jordi. Mil gracias a todos los que desde España nos vais a estar escuchando hoy en este primer webinar conjunto entre el proyecto ECMO de SEMICYUC y EuroELSO. Para nosotros es un paso importante, ¿no? En esa colaboración entre sociedades. And for our English speakers, just to say thank you very much. We are going to do most of this webinar in English, but some things in Spanish just to help our colleagues that maybe want to ask in the chat using Spanish, there's no problem. We are going to translate both, but the two lectures are going to be fully on English. So probably you will be able to follow most of our webinar. Just to start, it's for me a super pleasure to introduce Dinis the Reis Miranda. Dinis is an intensivist from the Erasmus Medical Center at Rotterdam, at the Netherlands. And he's leading probably the only and unique nationwide ECPR pre-hospital program in the world. So I think we can learn a lot of things from Dinis, and we will be very happy to hear you and also to answer questions. Please, por favor, escriben en el chat, write on the chat if you have questions, and after this talk, we are going to answer all of them. Please, Dinis.
Eduardo, muito obrigado por fantástica introdução. Thank you very much for a fantastic and very kind introduction. I'll share my screen. My main thing I think that I want to tell, main thing that I would like to tell is that the indication probably will be shockable rhythm. If you do it pre-hospital, pulmonary embolism in general is not a very good indication for ECPR. But in the pre-hospital phase, as low flow time is shorter, probably it will be a good indication for ECPR. And my main belief, and I hope that I will can make this concrete in a few months. My main belief is that pre-hospital ECPR is by far more favorable than transporting patients in cardiac arrest to the hospital and having ECPR in the hospital. So I think that if there is a larger vision of how the future will be, I think the future will be in not transporting the patients and doing pre-hospital unseen. Just a very short remark about transporting patients to the hospital. Is it useless? No, it's absolutely not useless. The REST trial now a few years ago showed in only 30 patients that ECPR, also done in the hospital, has a favorable outcome. But this was a very experienced center with a survival rate of approximately 40%. In the control group, almost no neurologic intact survivors. The break study was a little bit more neutral. There is no statistical difference in standard therapy or ECPR, and that is also transporting patients to the hospital for getting ECPR in the hospital. Why is this not significant? Most probably because in the standard group, there were a lot of crossovers, patients who actually did receive ECPR. And if you put it in a protocol analysis, the best, also for the break trial, the best is having ROSC, so having your own ECMO. The next best is having ECMO, and the worst case is not receiving ECMO. So I think also the Prague is a positive trial in large number of patients, almost 250, but was a little bit limited by the crossovers. And as last is the Dutch trial, the Inception trial, also transporting patients to the hospital. And there's absolutely no difference in ECPR versus conventional. And why is that? Because the Dutch were not much trained. The low flow time was 74 minutes. And in the arrest trial, it was 59. And in the Prague trial, it was 60 minutes. So the Inception trial had a long time of low flow. And why did we have a long time of low flow? Because at the ED, you had to wait for the cannulation team to get ready. 16 minutes of waiting time in the hospital to get a cannulation team. And that, I think, it is of an organizational quality which can be better, which can be improved. Why is that? Because cardiac arrest is a disease of time. This is per patient systematic review that we did, low flow time versus hospital survival. The yellow dots are conventional resuscitation, non-shockable rhythm. So you see that after 10 minutes, you're pretty much dead. The blue line is shockable rhythm, also conventional resuscitation, that after 20 minutes, you're approximately dead. And the red line is ECPR in almost 200,000 and almost 80,000 patients, I guess. And shockable and non-shockable. And there you have much better survival over all time points from 15 minutes off. And if you transport patients to the hospital, you usually between 60 and 75 minutes, and they have a huge ischemia reperfusion hit, which causes vasoplegia, diffuse intravascular coagulation, intestinal ischemia, and IRDS. And also persistent heart failure due to coronary problems. So you don't want to be in the 60, 75 minutes, as cardiac arrest is a disease of time. You want to be in the 30, 35 minute range. You can't be in the 30, 35 minute range if you do ECPR in the hospital. So having really low flow times, you have to go with your team pre-hospital. Just to show you again that there is something magical about the 45-minute mark is the study from Jason Bartus, and that pH suddenly lowered after 45 minutes of low flow time. Lactic acid plus suddenly rose after 45 minutes, and also PaCO2 suddenly rose after 45 minutes. So there is some magic about 45 minutes. You want to have the low flow time on 45 minutes or below. And again, I think, at least in Holland, it's only possible by doing pre-hospital ECPR. It's not possible by transporting patients to the hospital. So that's why my plea for getting pre-hospital ECPR. There's also a non-ethical thing about doing in-hospital ECPR. Is that you have to live quite near an ECPR center to be eligible for being transported to the hospital for doing ECPR in the hospital. If you are far away from an ECPR center, of course, the flow time would be too long to be eligible for ECPR. In Holland, we have 13 ECPR centers, and I drew a circle around each center where you may collapse to be at the hospital at 60 minutes after collapse. And now you see that approximately half of Holland is covered, a little bit less than half of Holland is covered. And the rest of Holland, if you don't get ROSC, you'll never get ROSC again. And this is the map of the 4 HEMS stations, and this is what you can reach in 30 minutes after collapse. So you can reach whole Holland, entire nation, you can reach with HEMS, making the whole nation eligible for ECPR instead of need to be living near a ECPR center to be eligible for ECPR. So there's also a fairness kind of thing. Does pre-hospital ECPR reduce low flow time? Yes, because those are the 3 studies transporting patients to the hospital. Low flow times between 60 and 75 minutes. Paris has, as the city so dense and they do everything by ground, they have a long low flow time, But Netherlands, Sydney, and London have a low flow time of approximately 45 minutes. Sydney has published 25 patients with a survival of 25%, and London has published 5 patients with a good neurologic outcome of 0. How does it go? Performing ECPR by HEMS, by regular HEMS team. In this video, I'll show you how it goes. The time from arrest to ECMO blood flow in this case was 33 minutes. Last part we go with police. So routinely put an EEG monitor during arrest.
Are you with the car?
ECMO blood flow for 33 minutes. And let's go to the hospital. We always do a video calling with ECMO consultants and perfusionists to make sure that the right settings are done. And here we have the arrival on the video. We have done this in the study, and the study is finished and soon to be submitted. And we did the study in step wedge design. And this is how it looks like. Lots of gear. We have two, in the HEMS, we have two operators, a HEMS physician, usually an anesthesiologist or a trauma surgeon, and a HEMS nurse, usually from the ambulance, especially trained to be a HEMS nurse. This is on scene at the beach. Wherever the collapse is, we cannulate. This is a 12-year-old kid drowning at sea. This is at a wedding. The priest collapsed and got resuscitated, got ECMO, and performed the wedding 3 months later. This is at the grocery stores. This 7-year-old kid with, in hindsight, sepsis, but we didn't know that by then. This is a video from our first case, and this shows the effects of very fast cannulation. This is the head side, the feet side. The clamps are on, and this is a video showing the clamps are going off and starting blood flow. This is at 35 minutes after collapse. ECMO blood flow running. And please look at his left arm. And his left arm, it starts moving. He wakes. And we really thought, at first we thought, well, this is a movie. First time, and we'll never make some movie again. And now, if you are at the 30-40 minute range, this is very usual. This is another example of fast cannulation. There was at the prison, was a guard who collapsed. We arrived at 8 minutes after collapse. We had ECMO blood flow at 35 minutes after collapse. At 80 minutes after collapse, he arrived at the cath lab, but he was awake while arriving at the cath lab, so we extubated him at the cath lab. After the procedure, it was circumflex, which was closed, was decannulation at the cath lab as good cardiac function was regained. He was transported to the ICU, not intubated and decannulated, and he was discharged to the cardiology ward 1 day later. 4 days later, he was home, and this is at day 7. This is a collapse at an exam center. Just going to give you some examples of very fast cannulation and the effects of very fast cannulation. We arrived at 10 minutes after collapse. We intubated, cardiac ultrasound showed no pericardial effusion. We start preparation at 15 minutes of cardiac arrest, dilation of the vessels at 20 minutes of cardiac arrest, and 22 minutes after initial arrest, we were on ECMO blood flow. And this is the guy still at scene. Spontaneous breathing, waking, and trying to extubate himself. And we allowed that. And this is the same guy on ECMO, going from the scene to the hospital.
Hey, wat is er?
Hoe kan ik je helpen? Still a bit post-anoxic. He got a coronary angiogram, was a main stem. The ECMO was removed the same day, and he went to the cardiology ward the next morning. This was drowning from a 16-year-old kid. The lifeguard saw him drowning and immediately called 911. He did not jump into the water, unfortunately, but just remembered the spot in which he sank. He was found at 10 meters of depth after 25 minutes, and that was clocked by the lifeguard. So at 25 minutes, being at 10 meters depth, he was found. This is at 25 minutes. He's getting out. At 39 minutes after initial drowning, he was on ECMO. And this is the kid after being 25 minutes at 10 meter depth. This is the kid now only have short-term memory problems and for the rest functioning very well. Just as a last remark for the effect of fast cannulation compared to in-hospital cannulation, we did a very small study, not published, for 45 patients. 20 patients cannulated on the ED by the intensivist, and 25 patients cannulated pre-hospital. And those 25 patients cannulated pre-hospital are only patients who are cannulated by the Rotterdam team and are on-scene protocol patients, but also off-scene protocol patients. If the patient does not comply at the rigid on-scene protocol patient, there is a possibility that they will be cannulated, but not in the study. And if you look at the effects for the ICU, the in-hospital, we have 20, pre-hospital 25, low flow time 60 versus 39. Norepinephrine requirement, the first 6 hours, 0.74 versus 0.38. The fluid balance, the first 24 hours, almost 4 liters versus 1.5 liter. So these are a completely set of different patients. If you are cannulated pre-hospital, your ischemic reperfusion injury is so much less. You have a total other kind of patient. It is not the same patient that you know from in-hospital ECPR cannulation. Those pre-hospital ECPR cannulated patients are really different. Also, the temperature at the arrival of the ED is different, 36 versus 34 degrees. And why is that important? Because at least at our part, our perfusionists put the heater cooler standard at 36 degrees. If you are hypothermic and you arrive at the ED and you are attached to an ECMO system with a heater cooler at 36 degrees, you rise from 34 to 36 degrees in approximately 20 minutes. And that's my firm belief that's really too fast. So our protocol now is that the heater cooler is set at body temperature at entrance temperature. So if the body temperature at entrance of the ED is 34.5, then the heater cooler is set at 34.5 for the next 24 hours. And then slow rewarming is initiated, but only then. That was my talk. I would conclude that I think that pre-hospital ECPR really has a lower low flow time, therefore lower ischemic reperfusion injury. Patients are really different, are less vasoplegic, and hopefully is the outcome better.
Thank you very much, Dinis. Was impressive, as always, what you did in the Netherlands. I'm just going to just summarize and translate a bit your talk in many sentences in Spanish, and then move forward with questions. There are some, and also I think you can read it, but I'm going to try to moderate, and also I have some questions for you. Simplemente un poco así, ¿no? En resumen, Dinis lo que nos ha venido a decir es que dentro del mundo de la reanimación extracorpórea, transportar a los pacientes al hospital no es una cosa inútil, ni mucho menos. Es la forma más generalizada que hay de hacer llegar el soporte extracorpóreo a la parada cardíaca refractaria, pero presenta límites, sobre todo, que solo permite que lleguen los pacientes que se encuentran cercanos a un centro hospitalario y que la parada cardíaca es una enfermedad tiempo dependiente y que nuestro objetivo tiene que ser bajar los tiempos de low flow, los de duración, ¿no? De ese RCP hasta la entrada en ECMO. Para ello, lo que vemos y lo que han estado viendo, sobre todo, ¿no? Ellos con su experiencia, y algunos artículos también que hay publicados, es que los tiempos de low flow, si nos acercamos a los 30 minutos, nos hacen tener un paciente diferente, ¿no? El típico paciente de aquellos que hacemos en RCP que vemos tras 60, 70 minutos, que son pacientes en fallo multiorgánico con una afectación brutal y una evolución a veces que nos llevan a la muerte por este fallo multiorgánico, si conseguimos poner estos pacientes en ECMO en un tiempo mucho más corto, vemos pacientes que se despiertan, que se mueven a entrar en ECMO, que incluso se llegan a extubar el mismo día, los que van bien neurológicamente, y que el modelo este de RCP, ECMO RCP prehospitalario, pues les ha abierto, ¿no? Una ventana a un perfil de paciente diferente al que estaban acostumbrados de ver con las canulaciones intrahospitalarias. Y con esto voy a pasar a las preguntas, que habían algunas por aquí. The first question, Dinis, to you is that they are asking, how do you manage in the helicopter to have a cardio help, all the material? Do you bring it always to every flight, or just in case that there is an cardiac arrest activation? And how do you work with this?
Yeah, we have Airbus 135, so a really small helicopter. And we always carry an ECMO system, always. So, and in case, especially for the redispatch, if you are at a trauma and you still are at the trauma and you get a redispatch for not for a resuscitation case, it's good that you don't have to be obliged to return to base, get your ECMO stuff, and then fly again. So the ECMO is always in the helicopter, and we also have an ambulance car if you can't fly. And the second ECMO kit, pre-primed, is in the ambulance car. So we have at the HEM station, we have two kits, two cardio helps, one in the helicopter always, and one in the car. And how to get it into the helicopter? And the chief pilot said, okay, you may put something in, but you first have to take something out. As usually, so we really went rigorously through the helicopter. But what can we take out? And we took approximately 30 kilos out to put the cardio help in.
So, nos cuenta que llevan los trastos, porque es la forma de, ¿no? de poder empalmar a veces servicios, de poder estar disponible cuando hay, porque nunca, eso es cierto, o sea, que hacemos también emergencias, que nunca sabes, ¿no? Lo que te vas a encontrar. There are other questions that I think are interesting related to how do you cannulate and what's your cannulation failure and complications related to cannulation, because probably most of our audience is afraid to cannulate an ECMO patient and many times more afraid to do it on scene, no? At the street. And if you feel that there's more complications than it on scene than in a more controlled environment like the hospital, what's your feeling on that?
Well,
and your experience?
Well, I think that ECPR is the most safest if you do it under how do you call it? Not ultrasound, fluoroscopy. Most safest, but it also costs the most time, and you're paying your feeling of safe. You're paying with time and therefore survival. So I think that in survival benefit, I think that pre-hospital is the best, and I think that ultrasound guided is the best. By far the best is doing ultrasound guided and TEE guided. So vascular ultrasound and TE guidance to see your guide wires. At our place, we don't have enough hands to do a TE, so we are limited. So we are going then for the next best is only do vascular ultrasound. We use, you put two guide wires in the ipsilateral groin and checking if you see two guide wires in two different vessels. That avoids a lot of trouble. You're only allowed to puncture if you have a clear vision on two vessels. If you have a blurred vision or if you are not sure if if you see the right vessels, you're not allowed to puncture. In rate of complications, to have retroperitoneal cannulus going through the vessel, we dealt with that complication by using super stiff wires. Using super stiff wires, we don't have this complication anymore. It went from 10% in the hospital to 0%. So what are the only complications that we have is VV ECMO or AA ECMO. That occurs in approximately 15% of the cases. So that's a lot. On the other side, in the study, control patients were allowed to be transported to the hospital to get ECPR in the hospital. The occurrence of cannulation failure was exactly the same. Why? And on the hindsight, if you go ask, okay, you had this complication, but why did this complication occur? 95% of all complications, the root cause was I was thinking I saw the vessels, really problem, but to be honest, no, I didn't saw the vessels very good, but I was pushed by the circumstances. I was pushed as the young children were crying. I was pushed because I was being in the living room. I was pushed because I set up a sterile drape and everyone was looking at me. Please perform it. And getting out of the train saying, I will not perform because I can't see very well, that is really hard. 95% of all cannulation failures had the root cause of inadequate ultrasound vision on the vessels.
Thank you, Dinis. Dinis nos ha dicho que, por supuesto, canular bajo escopia en un hospital es la mejor opción y si no, con eco transesofágico, pero que eso en el entorno extrahospitalario es algo que está limitado, con lo cual se tiene que hacer pues, una canulación que hacen siempre ecoguiada, percutánea y que básicamente utilizan ecografía vascular, es decir, solo ven arteria a nivel femoral y se aseguran que estén las dos guías en ambos vasos. La forma que ellos tienen de intentar disminuir, ¿no?, riesgos y complicaciones, utilizar guías de las ultra stiff, de las más rígidas, y que sobre todo las complicaciones que están teniendo son de tipo canulación accidental venovenosa o arterial, porque las dos guías acaban en el mismo vaso y las cánulas dentro, pero que comparado con sus programas de ECPR donde estaban haciendo canulación intrahospitalaria, la tasa de complicaciones es más o menos, o de imposibilidad de canulación es más o menos la misma, y que esa imposibilidad para canular siempre se está relacionando con pacientes en los cuales no tienes buena visión ecográfica, no identificas bien los vasos, y que eso son los principales limitantes, cosa que también pasa, ¿no?, y nos sucede en el hospital. Thank you very much. And it's just the last question and then we move forward. There are some questions regarding related to the team. How much people you are to perform this, how you are training the teams to be able to do this complex procedure. So I just want to know just a bit of this. Now, how many people is doing pre-hospital cannulation in your setting, and how is your training? You are training routinely per week, per month, and also at the beginning of your program, how did you train your teams to be able to perform this procedure on the street?
Thank you very much. First, we have 50 HEMS physicians and 40 HEMS nurses. 4 of those 50 HEMS physicians in whole Holland, 4 of those HEMS physicians of the 50 had ECMO experience. 46 had never seen ECMO before. The HEMS nurses had never seen ECMO before. So first the preschool, the preparation for the initial training was 2 videos, a book, and 4 podcasts. Those podcasts just to be a little bit more relaxed for running or bicycling or whatsoever. Then we have a kind of initial high intensity training. So with very small groups, 3 HEMS physicians and 3 HEMS nurses, with 2 simulation stations and 3 trainers. So one-on-one training, have 2 simulation days. and that is simulation and troubleshooting, but also simulating in confined spaces when it's cold outside. We go outside. We always train do the initial training in January. It's really cold in Holland. It's really wet, and then we go cannulate outside and really in confined spaces. That for 2 days, and then the following 2 days, three other people, 3 other doctors and 3 other nurses come, and we repeat the training. Thereafter, for 6 months, we go to the hem station again to train again each week. Every week we go again for 6 months. We go again to the hem station for retraining. And after this 6 months retraining, we retrain the whole team every 3 months because the rate that you actually cannulate is approximately 2-3 times each HEMS doctor. So that's not very much, and that's for Rotterdam. Other sites are even less. It's not much. So everything has to come from training. Besides that, if you have cannulated and you have ECMO blood flow, we don't teach post-ECPR ECMO management because that's a little bit too complicated. The post-ECPR management, we have it in a very standardized way. Just do it like this, but also do a video calling. Immediately after initiating ECMO blood flow, you do a video calling with ECMO intensivists and perfusionists just to show your settings, just to show how everything is set up, your norepinephrine, your filling rate, your fluid replacement, your ECMO settings, just to have this checked with people who do this every day. And also during transport, often they call again, these are my settings. Am I still okay? Am I still okay? In this way, we have guaranteed the cannulation phase, and we also have guaranteed the post cannulation phase, the ECPR management phase.
Thank you, Dinis. Un poquito, ¿no? Resumen. Simplemente para los que no conozcáis, el modelo holandés, que esto no lo ha dicho Dinis, pero como he estado con él viendo cómo se organizan, os lo cuento, se basa en ambulancias que van con enfermeros y tienen 4 helicópteros medicalizados con intensivistas, que son los únicos con médico en todo el país. Y son estos equipos los que se han formado en hacer ECPR. Partían de la base que solo 4 de los 50 profesionales médicos, ¿no?, que estaban trabajando aquí en estas ambulancias helicópteros tenían formación previa en ECMO, con lo que hicieron un proceso de formación bastante duro, intensivo inicial en grupos muy pequeños, en el cual pues empezaron primero con vídeos, estudiando, ¿no?, sobre papel, con podcast para que se entendiera el proceso, y después 3 médicos, 3 enfermeros, simulaciones a saco durante 2 días y durante 6 meses haciendo entrenamientos semanales sobre todo el proceso de canulación y entrada en ECMO para acabar pudiendo hacer este procedimiento. Después mantienen un entreno cada trimestral, cada 3 meses, porque la tasa de canulación, pues dicen que canulan pues 2-3 veces al año por el volumen que hay, ¿no?, y el número de gente que tienen. Y se apoya mucho en el hospital, que no han entrenado todo lo que es el post entrada en ECMO, sino que una vez el paciente está en ECMO, está canulado, lo que hacen es hacer una videollamada al equipo hospitalario y ellos les ayudan y les guían en la fase inicial de la resucitación, en la optimización de fluidos, ECMO, etcétera, y es la forma pues que ellos tienen de trabajar. Thank you very much, Dinis. I think it was super interesting to have your experience here, because for us you are the referent, no? The how to train, because we want to do the same. So we are trying to copy a bit how you are doing, and it's I have to say thank you very much, because you always help. if there's any question, you always are there to answer that.
Thank you very much. Pleasure to be here.
Jordi, no sé si tenemos alguna cosita más o creo que no, avanzamos.
Sí, claro
con
que
la siguiente.
18 preguntas más en el chat, las responderemos.
Wow.
We will answer all the questions now right in there to take them and continue asking everything you need, including these questions you have in your mind. Maybe Dinis can answer this. We will do it by writing, but we will jump to the next presentation through Nora. Nora, what do we have ahead? ¿Qué tenemos a continuación?
Hello, everyone. Just to start, I would like to thank the EuroELSO and the SEMICYUC to invite me to that amazing webinar. Antes de empezar, agradecer a la organización que me haya pedido la participación, que para mí es un honor estar aquí junto con estos expertos en la misma RCP. So, after the spectacular teaching done by Dinis, of a very nice speaking, a very nice and spectacular picture, I have to say, now we move on and we have another talk done by Ingrid and Marie Magret and Michael Pope. They are going to talk about aspect of cannulation and initial management. They are they work in the emergency medicine medical university hospital. So thank you very much, and we are just ready to hear.
Yep. Oh.
So can you hear us and see
Yes.
the presentation? Perfect. Thank you so much for having us at this amazing webinar. We are going to split our talk. So first of all, we are working in Vienna at this amazingly not beautiful university hospital located right in the center of Vienna. We have been doing cardiac arrest research and ECPR for many, many years. And we are working both as emergency physicians and working with the EMS. So we have both the perspective of how it is going on the street and how it is going on in hospital. Unfortunately, unlike Dinis, we at the moment can only perform ECPR in hospital. So we have to transport our patients from the site of arrest with ongoing CPR to the hospital for ECMO initiation. Where do we get our patients from? We get them from all of the city of Vienna. We are located quite centrally by ground, but also from the surrounding areas of Vienna main city. So everything that can reach us with ground transport or helicopter transport within a reasonable amount of time, meaning 60 minutes to ECMO flow target, is treated by our center with ECPR. And with this, I can give over to my colleague, Michael Poppe, who will talk about the practical aspects of how we do ECPR cannulation.
Thank you very much. So the practical aspects of cannulation is quite easy, honestly. It's always a sequence of 4 steps. You have to have a verification of the vessels where you're going through. You have a verification of the wires where you put it in. You have to dilate this whole area, and you have to put the cannulas inside. So this sounds quite easy, but in fact, it's not so easy as maybe Dinis claims it. But however, first of all, we're going to start with the vessel verification. There are different methods to do it. You can do it via an ultrasound, which is the most used way, as you see it is here. You can do it directly and open, like Paris did it for the last 15 years, or you can do it on a very, very, very old-fashioned way using landmarks, which I personally would not recommend because this is maybe the most unsure method you ever can use. For example, this guy was tried to cannulate without ultrasound, and you see the lot of holes where they thought the vessels are. Actually, the vessels were there. We saw them in ultrasound afterwards. So first of all, you're going to really have to verify your vessel where you're going to puncture. Then, and special for the artery, of course, always look for the bifurcation. The bifurcation is the area you are targeting for, and you always want to puncture between the bifurcation and the ligamentum. And this is the right precision. Robbed a little bit from Lionel Lamont's picture, but this illustrates it best. You always want to be somewhere here. So when you punctured the vessel, the first is done. Now you have to put some wires in. And the wire verification is extremely, extremely important. And I just want to follow Dinis. We are doing it exactly the same way. We have 2 wires in 2 vessels, and you always have to confirm this. You can confirm this into the groin, when you see two vessels in two different wires. Under resuscitation, both vessels are collapsing, and you can't really see a difference sometimes. So if you have this picture on the ultrasound, you can be quite sure that at least you're not AA or not VV. You can all do this also from the abdominal or thoracic view. We in Vienna using transesophageal echo in a routine manner. First to guide the resuscitation itself and also to guide the ECMO cannulation. Here you see clear a wire in the descending aorta, and here you see clear a wire in the right atrium. So if the wires are there, you can be very sure that their cannula position will be correct. You don't need a TOE. You can also do it with abdominal ultrasound. Same procedure or same rule. You have two wires in two vessels, and then you are quite sure. Of course, there are centers which perform ECPR in the cath lab, and when you have fluoroscopy and you see the wires in the fluoroscopy, thank you, Rob from Prague for this picture, and you can be quite sure as well. But as Dinis said, if you have no clear vision and you don't have a clear verification of the wires in the right vessels, you're never allowed to dilate. This can cause huge complications, bleeding, and bring all the efforts to a non-good end. So now you have the right vessel, you have the verification of the wires. Dilation is not so without any, I would say, risk. First of all, you really have to know what do you want to put in. In Vienna, we always use 15 or 70 French for the arterial line and 23 French for the venous, for the drainage line. So that means you have to know your sizes, what you're going to put in. And of course, you have to know what wires you use, because this has an impact on the way how you dilate. We are using nowadays, most of the time, super stiff wires. They are just not as floppy as the Maquet wires, but have a lot more backup for everything, for the dilators and for the cannulas itself. So when you know what wires you're going to put in, the choice of dilators will also have an impact on that. In the normal Maquet set, there are from 12 to 18 French dilators. And of course, there are more dilators if you really need big holes. We honestly almost never use this. The Vienna approach, and this is not a general recommendation, it's just our way. We are doing it with only one dilation for arterial and one dilation for venous, with a 16 French and an 18 French dilator. But, and this is a very but, try not to overdilate and make an adequate incision. There are only two difficult points while putting the dilators or the cannulas in. First is the skin, and second is the tip of the cannula in the front when you're going through the vessel wall. The vessel wall is quite easy, but the skin can be really, really, really hard to get a 23 French cannula in an 18 French hole. So you really have to make an adequate incision of the skin. And if you do that, you can avoid a lot of problems. After the dilation, you just have to put the cannulas in. The cannulas usually, not usually, the cannulas have their own dilator, and we call it soul. Usually helps a lot while putting the cannulas in. One very, very important thing, you should place the venous cannula up into the vena cava superior. Ingrid will talk about that a lot in the next part of the talk. And for that, you really have to be aware that the very, very sharp tip of the white dilator could cause injuries on the right atrium. So before you put the venous cannula completely in, and in a special during cardiac arrest and cardiac massage, retract the white dilator before you're putting in the cannula fully. Why I say fully? In the human, the normal adult male, the 55 centimeters venous drainage cannula is completely correct when you just put it completely in. And where is the correct place? We are trying it to put it with the tip into the vena cava superior, and we always prove it with the echo, or if you have the possibility on fluoroscopy. This brings a lot of advantages. Usually the drainage is quite better, and the differential hypoxemia in dual circulation will be a little bit, you can overcome that problem a little bit, but this is Ingrid's part right now. So after everything, ECMO is running and patient is safe. So usually we say ECMO on, where it's gone. Obviously it's not, and now the real work starts, and I give over to Ingrid for the practical aspects of the initial management after cannulation.
Thank you, Michael. So we put the ECMO in, what now? I fully agree with Dinis. This is a much more difficult topic, I believe, to teach than how to cannulate. We try to make it as simple as possible and try to teach ECMO in a nutshell to all our residents and all our team members, nurses and doctors alike. But still, of course, this is an oversimplification of something that is quite complicated. So basically, it's all about perfusion and oxygenation. So you need perfusion of the body, you need oxygenation of the body. There is a couple of ways how to measure it, but it is not so easy, maybe, neither the perfusion nor the oxygenation part. So if we break it down, there's a couple of steps that we want to make sure. We want to ensure the ECMO is actually running and ensure ECMO circulation. We want to ensure oxygenation. We need to treat the cause of cardiac arrest to be able to ensure native circulation and pulsatility to take over from ECMO circulation. So first things first, once you get the ECMO running, is there any bleeding? Is there anything that you need to do right now that you see that is going to prohibit to get this ECMO running? We stole this idea from Dinis, who told us that they just put a pelvic binder on all the patients. We now are also very generous with pelvic binders. So if there is just some bleeding going on from the cannulation side, maybe it be a lot, maybe a little, we put some binders on because we are on the road with the patient a lot. We go to the cath lab, we go to the CT scan, and it's just better if you do not have any external bleeding that is maybe not necessary. Then you need sufficient perfusion. So you need flow, basically. How do we target that? We target a mean arterial pressure of 60 to 80 millimeters of mercury. And firstly, we target it with an adequate ECMO flow of 4 liters or more, if possible. If you put in a large enough venous cannula, and if you put it, as Michael said, up into the right atrium or superior vena cava, you can usually achieve that. We try to get a right radial arterial access as soon as possible once the ECMO is running. First of all, to target MAP, but also to target oxygenation, as I talk about later. We are happy with 2 or 3 peripheral venous lines, so something where we can get fluid in and something where we get a basic dose of vasoconstrictors in. So all our patients get noradrenaline already during the cannulation process so that it is in the system once the ECMO is running, and get 1 to 2 liters of crystalloids coupled with 100 or 200 milliliters of albumin. As Dinis said, we also try to make things standardized, have a package ready, try not to overcomplicate things. And this package is good for most every patient. Maybe they need more, but you will not harm a patient usually if you just give them this package. If you have drainage insufficiency, there is really one thing you have to think always first. This is complications. Is there bleeding, external or internal? Is there some form of obstruction, meaning cardiac tamponade, meaning tension pneumothorax, or is there some other cause of hypovolemia? Our patients are unfortunately not as fast on ECMO as Dinis patients are, so they're in a median more like 60 minutes of CPR. This means there is a lot more of vasoplegia going on, they usually need more volume, they usually need more vasopressors. And you have to differentiate those problems. And lastly, make sure the cannula, the venous cannula is in the right place, make sure the cannulas are secured, reposition if necessary, and then get everything sutured and dressed. So the first thing, we have the ECMO running stable. Now we have to make sure the body is oxygenated or we are in the right target range. So every patient gets an airway, an ET tube. Our patients usually don't wake up once the ECMO is running. As I said, we're a bit later than Dinis is with his ECMO patients, but make sure the tube is correctly placed and reposition if necessary. Make sure there is bilateral ventilation, again, tension pneumothorax, and treat if necessary. And we have some basic initial ventilation settings that work for most patients. And we target, as I said, the right radial artery, the right upper limb with these oxygenation and CO2 targets. How do we set it? We simply just set both the ventilator and the ECMO blender. If we are hyperoxic, we reduce both of them and don't think too much about the mixing point, but more on that later. We always use capnography, not so much for ventilation, but also for hemodynamic targeting or monitoring. What we try to avoid hyperoxygenation, which means we always have a blender going on. We always mix air and oxygen to target our PaO2, and of course also avoid hypocapnia. Your ECMO machine is very, very potent in reducing CO2 from the blood. So if you turn it up too much, you can go very low very fast. So be careful. Treating the cause of arrest, with most I mean 90% of our ECPR population are men, and they mostly have ventricular fibrillation, or some centers even only put patients with ventricular fibrillation on ECMO, and those patients mostly have a myocardial infarction as cause of arrest. So the prevalence of myocardial infarction is very high. If the patient has ventricular fibrillation, we defibrillate, we put a lot of electrolytes to keep the rhythm stable and also antiarrhythmics, and we will always go to the cath lab. If there is no ventricular fibrillation as initial rhythm, we do a 12-lead ECG, or we always do a 12-lead ECG. If there is signs of ST elevation or acute ischemia, or if we have any other reason to believe it is a myocardial infarction, patients will also go to the cath lab. So put it simply, most every patient will go to the cath lab unless you have a very good reason to believe there is another cause of cardiac arrest. Maybe pulmonary embolism, or quite obvious, maybe hypothermic cardiac arrest. But all other patients will end up in the cath lab for reperfusion and treatment of the cardiac arrest. And lastly, we want to get the native circulation running. We want to achieve pulsatility. It is not good if the heart is not ejecting, because there might be LV overdistension, there may be thrombus formation, you may end up in lung edema. So you want to get the heart ejecting, firstly by having treated the cause of arrest, but also by titrating the ECMO flow to help the heart eject, by giving some for some low dose or some needed inotropes, plus minus, if the heart is really not ejecting. If, for example, there is a myocarditis that cannot be treated fast, you have to think about active ways of LV unloading. Although in Vienna, at least, this is only really in 5 to 10% of patients the case. Most patients eject just fine once they have been reperfused in the cath lab, or once they have been reoxygenated and reperfused with ECMO. So about this mixing point that I mentioned before, we try to avoid too complicated physiology, but this is something that really everybody needs to know, all our nurses, all our registrars. You have two flows going on in ECMO. You have in red the ECMO flow, and you have in blue the native cardiac flow. and they are working usually against each other, or they are in opposite directions. And the coronary arteries and the cerebral arteries, they are most proximal to the heart. So even if the heart is only working a little bit, the coronary arteries and usually also the carotid arteries will be perfused by your ECMO, by your native heart, and therefore by your lung. This is why we will always get our SpO2 and our blood gases from the right radial artery, which is really the first accessible artery. So thinking that if this blood gas is fine, the rest of the cerebral arteries and the rest of the brain will also be fine. This mixing point is highly dynamic. So if the heart function improves, it will move more distally. If you turn up the ECMO flow, it will move more proximal. And of course, things like inotropes and impeller can move the mixing point more distally also, and can I will show that later, worsen things like differential hypoxemia as well. So be aware, you want to target the right hand as a surrogate parameter for your brain. So once we have all this done, we are happy. We can say we did our initial management. Just always be aware, ECPR produces mainly two things, perfusion and problems. So something that you will encounter often is this beautiful sound where you have reduced venous pressures and reduced ECMO flow, called drainage insufficiency. And you always have to think about the same things. Is your cannulas correctly positioned? Do you have hypovolemia? Do patients need volume? Patients initially need a lot of volume if the resuscitation was going on for a long time. If they have a lot of vasoplegia, they will need some vasopressors. And then if you have thought about this, always rule out complications. Think bleeding. Even if your surgeon told you, no, everything worked perfectly fine, there was certainly no mispuncture and I didn't overdilate, always think bleeding. Always rule out tension pneumothorax. We have been resuscitating our patient for an hour. They have rib fractures always. They have pneumothorax always, not always tension pneumothorax, but rule that out. And think about things that you have usually not seen in your standard CPR patient. For example, tamponade from rib fractures, tamponade from sternum fractures, tamponade from ribs that puncture the heart, things that were not bleeding during CPR, but once you're well perfused with ECMO, they will start to bleed. If ECMO flow is dropping rapidly, or if you lose pulsatility, or if you have a sudden drop of CO2, search for complications. So you will not believe it until you live through it. We had this patient, everything was working fine. Suddenly the flow dropped from 4 liters to 1 liter, 1.5 liters. There was a pneumothorax on the right side. And after draining the pneumothorax, everything was working perfectly again. If you don't think about it, if you don't look for it, you will oversee it and you cannot cope with this problem otherwise. Another problem you might encounter, sudden drop of SpO2 on your right index finger on your radial arterial axis. So everything was working fine initially, and suddenly the blood gas goes very bad. This is the CT scan of the patient. She drowned, so she had very bad lungs, but she had a beautifully working heart. So the not so well oxygenated native blood was pumped through the body with her very good working heart, called differential hypoxemia. This is bad because the brain will be oxygenated just like your right index finger. Try to optimize ventilation. As Michael said before, push the drainage cannula as far up as possible, drain the darkest blood to overcome some of the differential hypoxemia, And maybe in some cases, you even have to think about VAV ECMO reconfiguration. Limb ischemia. Don't wait for your limbs to go like that. Get a distal perfusion cannula running. Important, look at this blood. This is from the common femoral artery. It was very, 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 very dark before when we inserted the distal perfusion cannula. This is how the limb is perfused, and reperfuse it with properly oxygenated ECMO blood. Recommendation from our side: use products that are intended for the usage. For example, there is proper distal perfusion cannulas. They don't have a three-way stopcock, so they don't have like a very narrow tip where the blood flow gets limited, but they can nicely reperfuse the leg. And lastly, all our patients go to the CT scan from head to limb, and we get a standardized protocol. We have our friendly radiologists on board. We search for a cause of arrest if it was not ACS, but most importantly, we actively search for complications from both CPR, from cannulation, cannula malpositions, and any other injury that the patient might have had during CPR or during the cannulation process, to maybe be aware of them before we even clinically find them or see them. Lastly, at least in our center, we often experience there is a loss of momentum once the cannulas are in. The adrenaline drops, we are happy, but you have to continue going. Cannulation is really only the start of what you have to do with your patient. As I said, don't play catch up with your patient, be prepared, anticipate complications, and have everything as much standardized as possible to make it easy for everybody in the team. For example, we have those ECPR boxes that were introduced by our nurses actually. They have this whole package of initial medication inside. So the albumin, the fluids, the noradrenaline, the heparin, the antibiotic that we give. And the nurses know that the whole content of this box needs to be in the patient within the first half hour, so we don't forget anything. And everything, of course, is a very dynamic process. We need to stabilize, we have to do diagnostics, and then we do everything else. So prioritize what is important in the right order. And as I said, the real work, I think, really starts once the cannulas are in and after you have done your cannulation. With that, I want to thank you, and we both are open for questions.
Thank you, Ingrid and Michael, for the talk. It has been very, very practical, and I'm very sure we have learned a lot. So I'm going to do a small summarize in Spanish. It will be maybe 1 minute or so. Entonces, lo que han hecho Michael y Ingrid básicamente ha sido dividir su charla en dos partes. Por una parte teníamos la de Michael, que sobre todo lo que hablaba era un poco el circuito que se seguía a la hora de hacer la cannulación. Ha ido dándole importancia a los diferentes pasos, como por ejemplo la importancia de la verificación, de nunca dilatar si no se está seguro de lo que se ve, y en general algunos consejos para que la cannulación sea lo más segura posible. Y posteriormente Ingrid lo que ha hecho es un resumen de lo principal o los aspectos más importantes a hacer una vez ya tenga el paciente pues, el ECMO puesto: la importancia de la perfusión, de la oxigenación, de ir tratando la diferencial de oxigenación y asegurar una adecuada descarga del ventrículo izquierdo. So I think we're going to just go through the questions. So yes, there are a few questions. For example, there are one here. It asks how much time do you take to decide to go on CPR, ECPR?
Really, since we do not have the luxury of going pre-hospital, we decide very early. So within 10 minutes of arrival of the EMS on scene, which will be usually within 20 minutes from the start of cardiac arrest, we make the decision. And ideally, by that time, the patient is already packed up and ready for extrication and transport. So to put it even more urgent, the ideal ECPR patient, if you identify him or her during the EMS call, which means witnessed arrest, ongoing CPR, and under a presumed age of 70 years, the EMS will already think ECPR on the way to the patient. So the EMS call will already have the small text potential ECPR patient, so that their mindset is already prepared when going there. But decision is really made after the third shock or within the first 10 minutes of ALS.
Entonces, la pregunta sobre todo era acerca de cuánto tiempo se tardaba a la hora de activar el ECMO RCP. Y Ingrid, claro, lo que comenta que a diferencia de aquellos servicios que sí que tienen prehospitalario, aquí la decisión es bastante más pronta en comparación. Incluso los 20 minutos consideran ya el iniciar, incluso que el paciente tenga que tenerlo todo preparado. Y además, en relación a pacientes que vengan de esta hospitalaria, que vienen ya parados, reciben ya una mensajería de que el paciente viene y incluso ya el tercer choque se decide ya todo esto. So yes, there are a few questions about the cannula. There are one question about the return cannula. They want to know the size, and also if you put a distal link reperfusion cannula.
Okay, so the return cannula, the arterial cannula in our system usually is a 17 French or a 15 French in very small females or women. And the drainage cannula is at least a 21, but in the most, I would say 95% of the time, a 23 French cannula.
And
the distal one, we are using the dedicated cannula, which is metal griddled and has no stopcock on it. And this is a 7 French cannula.
Lo que usan de cánula arterial suele ser una 17 y en el venoso al menos 21, pero casi todos 23. Y en el reperfusión, pues sí que usan una que, por ejemplo, son al menos de 7 French. Do you have in your hospital, sorry, Jordi, do you want to say something?
Yes, thank you very much. Amazing presentations. Only I will switch to Spanish. Es una muy buena cuestión, yo creo, las cánulas. En la presentación me parece que ha salido 18, por eso yo creo, la pregunta era en inglés, así que luego preguntaré en inglés. 18 en la presentación, pero sí que 18 queda un poco justo. Yo creo que es importante el tamaño, que como 23, 25 diría yo, y sobre todo la posición, que lo ha dicho muy bien Michael, que tiene que estar bien arriba la cánula, que cruce la aurícula derecha. Recordad que es dependiente el flujo que crees del diámetro de la cánula, pero también del continente donde esté la cánula. Recordad que la aurícula derecha está más ampliada, más desplegada. 1, por eso tienes que atravesarla, y 2, porque tienes que meter en el circuito ECMO la sangre más desoxigenada, que teóricamente es territorio superior. Creo que solo quería apuntar esto, Nora. I'm telling just briefly that in presentation, I think, Michael, that the figure, it was 18, but you nicely have shared with us that 21, most of the cases 23, that gives you more potential to increase the ECMO blood flow. Thank you. Nora.
Yes, there are also a question about if you know the car system. Do you have any experience about that?
Yes, we have been using the CARL system for 10 patients. So we did a kind of a pilot trial. It's working perfectly fine. It has some advantages. For example, it has an onboard blood gas measurement. So you don't have to draw blood gases, but it can draw them from the arterial line. It has an onboard blood pressure measurement option, so you can insert a blood pressure measurement sensor into the arterial return cannula and connect it to the car sensor to get a blood pressure. And also it has an option to have a venous access or access on the venous line to apply medication, for example, or or give rapid infusions. However, many of the things don't work so perfectly yet, or for example, the blood gas can measure oxygen but not CO2. And while we were quite happy using the system, it was not enough for us to change from our current standard to the CAL system. And it is difficult. We have in our hospital Fresenius Xenius, we have cardio help, and we wouldn't want to have a third system if that is if we don't have like all the ICUs and everybody else on board who wants to change. So we did the pilot trial. It was working really fine. I think there is a lot of good ideas. But honestly, I think the whole system needs to shrink to like half size and half weight to really be competitive with the cardio help and remain all the features, of course, which are great.
Sorry, just to clarify the question from before because of the 18 French. I meant we use 18 French dilator for the 23 French cannula. That was, no, I just rechecked.
Bueno, Michael justo acaba de hacer una pequeña comentario acerca de los French, que eran dilatadores de 18, pero que realmente lo canulan al menos de 23. Y Ingrid sí que ha comentado que usan el sistema CAL, que les generaba algunos beneficios, que hay algunas ideas interesantes acerca de ese sistema, como por ejemplo determinados gases. Lo que pasa es que no terminaba de ser para ellos tan competitivo o lo suficientemente adecuado como para decidir el cambio de sistema. So, Jordi, I think you want to say something.
Yeah, sorry again. Solo un apunte en castellano. El Carl también tiene estoy de acuerdo en general con lo que dice Ingrid, tiene dos circunstancias. Nosotros no lo hemos usado en pacientes, lo hemos usado en modelo porcino para probarlo. Dos circunstancias atractivas. Uno es el componente del priming, del purgado, que es una solución neuroprotectora, pero que no sabemos, no tenemos, obviamente, porque está protegido, exactamente de qué, probablemente amanitol, etcétera, serán hipertónicos, probablemente, cosa que en general es atractiva, pero como no sabe los detalles, pues bueno, tienes que fiar un poco. Y luego otra cuestión que sí que es interesante, que es que monitoriza la presión en la aorta, porque pones un sensor de presión a través del retorno. Yo creo que esto en general esto es bastante atractivo, pero luego tiene otras cuestiones. También genera ¿no? Tiene dos bombas, entonces puede generar flujo pulsátil, pero claro, si tú teóricamente ECPR, si lo aplicas bien, el ROSC tienes en los estudios más del 90%, ¿no? Vuelven a tener pulsatilidad basal, digamos, ¿no? Entonces, pero bueno, es un sistema a tener en cuenta diseñado específicamente para ECMO.
I think the majority of the question has been answered. I would like to ask something. No, there are one more. Yes. There are one question, but I think it's for out of cardiac arrest. So, do you have any experience for Colibri for the small transport ECMO?
This is the Eurosets. You know Colibri?
Yeah. So we don't have experience with Colibri, but we will have experience with Colibri because our perfusionists and are going to try it, and we are going to try it as well in the ECPR setting. So in maybe 1 year from now, we can tell a little bit about the system. I think the system itself comes with some big benefits just because of the size. And I think it's worth to try it. We'll see.
But the normal Eurosets, we did it, not us, but the hospital did a trial. We were not happy with that. We were really unhappy with that because it is very bulky, very big, with no apparent advantages whatsoever, at least in our experience.
Michael and Ingrid, I would like to ask you one question about your teaching program. How do you do to do all the learning things about the cannulation? How do you have performed that teaching?
So this is a two-part question, I believe. So the one thing is we try to get everybody who wants to participate on board, meaning both nurses and both our physician colleagues are invited to our cannulation trainings. But this mostly or basically or primarily means everybody should know the equipment, everybody should know the standard approach, and everybody should be able to assist in the cannulation process. The person who is actually doing the vessel puncture and putting in the cannulas, this is a small concentrated team. At the moment, we are 5 people, because even though we do a lot of ECPR, it is still no more than maybe 40-50 cannulations per year for us, and the other half is done by the cardiac surgeons. So the exposure for each and every one is still small, and as with everything complicated, you get better if you do more of the same thing. So the actual team who puts the cannulas in is a rather small team, but the team who is assisting with cannulation and with equipment preparation, we try to keep that as big as possible. And also the team who is able to do the transesophageal echo is as big as possible.
Había aprovechado la oportunidad para preguntarle a Michael y a Ingrid una pregunta que ya se hizo a Dinis para ver cómo ellos hacían la parte formativa. Ellos lo que comentan que lo que es el equipo de canulación son un equipo algo más pequeño, entre 4 o 5 personas, mientras que el equipo que asiste a esa canulación o que incluso hace la ecografía transesofágica durante la canulación, sí que les gusta que sea o el mayor o al menos el que permiten que más gente participe. El hecho de que sea un número más reducido sobre todo se basa en, dado la necesidad de tener una curva de aprendizaje elevada y el número de casos que suelen tener al año realizado por ellos, que son en torno a 14-15, mientras que los demás lo hacen los cardíacos, pues prefieren de momento reducir el número. Okay. Yeah, I think almost this is. I think we have done and answered all the question. I don't know if Jordi or Eduard, do you want to ask anything? Or we maybe...
Edu, may I speak with these two guys here and ask them only one question? Yeah, I always, when I read ECMO papers, I always look at the cause of death. I think it's very important. It's very important. And in ECPR in general is neurological bad outcome. And the other thing is multi-organ failure. And I have to tell all the intensivists, stop with this cause of death. Multi-organ failure is like, well, everything failed. I know that when the patient dies, everything is failing, no? And I always wonder, multi-organ failure, right? That probably this is something, a label for the vasoplegic situation that you raised, Ingrid, that is very difficult to be managed. These two situations, mostly here we have more the neurological situation, but the other one is present. And I know this question is very difficult and the answer never knows, but how can we manage this vasoplegia? You told about fluids, but we all know that positive fluid balance is always related with bad outcome. So yeah, we try 24 hours and then try for negative. This is my first question. If you have any approach on this. And the other thing is neuroprognostication. Which variable do you use during the first phases, or to think about maybe in the future the neurological outcome of this patient will be bad, and also which therapeutics in terms of body temperature do you go for 33, 35, or so? Sorry, these two questions for you.
maybe I can start. Sorry if pointing out that fluid is a solution. Fluid is a rescue option if nothing other things work. So obviously we are facing a lot of problems with the initial phase with vasoplegia, and we all know these capillary leak problems and whatever. So how to manage it? Honestly, don't know.
Short and low flow duration.
Honestly, I really don't know. We are trying different things. Albumin, we're trying this blue stuff. How is it called?
Methylene blue methylene.
Yes. And honestly, we are just trying to minimize the post-cardiac arrest syndrome, and this can be minimized mostly with the time. So we are always trying to find a good mixture between catecholamines, fluids, and ECMO run. I don't know where the right relation is, honestly.
And also, I believe work cleanly, the less cannulation complications you have, the less secondary injury you have from bleeding complications, the more stable your patient will also be.
I took this from Dinis. This out hospital when you have to face and you have to explain someone, we should go to the streets and cannulate. This is important because, and that I took this from his talk, honestly, that you decrease one of the most frequent situations when you start a flow, which is vasoplegia. That was fantastic. What about neuro?
So basically, the neuroprognostication follows the standard neuroprognostication of cardiac arrest patients, meaning that on day 2 and 3, you get NSE values, you get SSCPs, you get EEG, you get CT scans. But our ICUs are very much aware that awakening is possible on day 2 or 3, but usually takes longer. So the median is 6 days in our patients, not always due to neurologic problems, but due to secondary problems, like they have aspiration pneumonia, they just need sedation, so you cannot wake them up and you have to wait. So we do not do very early neuroprognostication. Or at least in most of our patients, we try to give them as much time as they need to have a realistic chance to wake up. And if neuroprognostication is good, meaning your EEG, your SSCPs, your CT scan, your NSE values are good, we are prepared to wait for 7 days, for 14 days, for however long it may take until the patient wakes up. Regarding treatment of hypoxic ischemic injury, yes, I didn't mention it in the talk specifically, but all our patients are being cooled to 33 degrees. With the help of the ECMO, you have a perfect cooling device. So we put the heater cooler actually to 15 degrees, and we flush the patient with very cold initial ECMO blood flow, which means most patients get cooled within half an hour to an hour at most. And then we keep them at 33 degrees for 24 hours, unless there is complications like bleeding that will demand to target a higher temperature.
Thank you very much, Edu.
So thank you very much. I think we are arriving to the end. I have just the last question, please. Very short answer, maybe to conclude and to end. And it's a situation. Imagine that you have a patient on cardiac arrest in front of you. ALS is started, patient is already intubated, 3 shocks, 1 milligram of epi, 300 milligrams of amiodarone. You have the competence to cannulate the patient, you have the material. At what point, time, moment, you decide to start cannulation and to move forward with ECPR?
Well, realistically speaking, even if you cannulate very fast with the whole washing and draping procedure, you will probably take 8 minutes to cannulate. So initial is never initial. or immediate is never immediate, let's put it that way. And maybe we didn't mention it specifically in the talk, but we changed our approach now from direct needle puncture and wires to sheaths. And this has allowed us to be a bit more flexible in terms of re-evaluation. So we would, I think, put immediate sheaths into the common femoral artery and vein, have secured vessel access so that we can re-evaluate maybe after a couple of minutes of CPR, 10 minutes of ALS, if we want to proceed with cannulation. But I wouldn't wait too long.
I would say exactly the same. Start immediate with cannulation. It means put sheath in, put wires in, wait. If the patient is going the next 10 minutes, no ROSC, go for it.
And if they have ROSC, you have central venous access and arterial blood pressure measurement, which is nice for post-resuscitation care.
Thank you very much. Les pregunté simplemente que si no tenías un paciente delante con una parada cardíaca, se estaba haciendo los primeros minutos de soporte vital avanzado, ¿en qué momento, no, teniendo el personal, el equipo y la capacidad de poner un paciente en ECMO, deciden empezar? Y su respuesta era enfocada a no esperar, y que ellos lo que suelen hacer es un primer paso de poner introductores arterial y venoso, lo que permite, si el paciente mientras tanto consigue recuperación de la circulación espontánea, monitorizar la presión arterial invasiva, tener un catéter o no, una vía venosa central para el manejo posterior, con lo que, como resumen, no esperan porque, ¿no? Como creo que ya hemos dicho bastante, el tiempo, ¿no?, es cerebro, y el tiempo de low flow se relaciona directamente con la supervivencia y con los resultados de los programas de reanimación extracorpórea. Creo que con esto, Jordi, cerramos. No sé si quieres hacer un mini cierre en English y luego cierro en Spanish, o Nora añadir alguna cosita y nos vamos para casa.
Por mi parte, agradecer sobre todo a los asistentes el que hayan estado aquí, 184, ahora ha habido un pico de 250, me parece fascinante, y todo esto gracias a los ponentes. Dinis se ha tenido que marchar, agradece mucho la amabilidad, las cuestiones, las preguntas, espero que se han respondido todas. Agradeceros a vosotros, Nora y Edu, el que hayáis estado moderando este fantástico webinar, y voy a cambiar el inglés. I will switch to English to thank you, Michael and Ingrid. You are fantastic professionals. We always look at you and we follow what you do, and you know, this networking is very important for us because we like to optimize what we offer to the patients. That's why we are all here. So thank you for this. Maybe next year, I think you told us that next year, Michael, you will explain. I don't know why the colibri. Anyway, you will be here, and again, maybe in Spanish, who knows? But thank you very much. Nada más, me lío un poco, Edu y Nora, si queréis cerrar.
Nada. Yo decir lo mismo. Uy, Nora, venga.
No, me da igual, dale.
No, simplemente eso, dar las gracias a todos, y lo único que quería recordar para nuestros oyentes españoles es que a final de este mes tenemos las primeras jornadas de actualización en ECMO, donde estaremos pues nosotros tres y muchísimos más expertos nacionales, que esperamos que sean un punto de encuentro para vernos, para hablar, para compartir, para aprender todos unos de otros, para poder empezar también proyectos de investigación. Así que si aquellos que todavía no estáis apuntados o lo estáis pensando, os animamos muchísimo a venir a Madrid, donde tendremos 2 días llenos de ECMO en todas sus vertientes: veno arterial, veno venoso, ECPR, donación, transporte. Tendremos también reunión de grupo de trabajo donde podremos espero que avanzar y plantear muchas cosas interesantes. Así que os invito y os animo a venir. Y gracias por escucharnos, gracias por estar ahí, gracias, Nora, por estar también hoy aquí como moderadora, y a Jordi, y a Michael, y a Dinis, que ya se fue. Y Jordi.
Can I say something, Edu? If not, Christian will kill me. Also, please join us in Dublin, EuroELSO Congress. EuroELSO Congress in May. We have an amazing program also. Yes, you will be there. I'll invite you to join us there in Dublin. Edu también y Nora maybe, pero seguro, Nora, que nos vemos en Madrid, ¿sí?
Sí, eso seguro que nos vemos en Madrid.
Fantástico. Muy bien, pues cerramos.
Thank
Chao.
you very
Vaya
much.
bien.
Bye-bye.